Hello everybody, welcome our YouTube channel number 1 Doctor. Today we will talk about acute abdomen. As a part of our series short medical notes, please do not forget to like and share our video. Subscribe to our YouTube channel, follow us on social media accounts. The links in the description below the video. Acute abdominal pain can be caused by perforation, obstruction, and inflammatory or ischemic processes. Each of these groups has some common identifying characteristics. Acute abdominal pain caused by perforation has sudden onset and is constant, generalized, and very severe. The patient is reluctant to move, and very protective of his abdomen. Except in the very old or very sick, impressive generalized signs of peritoneal irritation are found: tenderness, muscle guarding, rebound, silent abdomen. If present, free air under the diaphragm in upright X-rays confirms the diagnosis. Perforated peptic ulcer is the most common example. Emergency surgery is needed. Acute abdominal pain caused by obstruction of a narrow duct ureter, cystic, or common has sudden onset of very severe colicky pain, with typical location and radiation according to source. The patient moves constantly, seeking a position of comfort.
There are few physical findings, and they are limited to the area where the process is. Acute abdominal pain caused by inflammatory process has gradual onset and slow build-up at the very least a couple of hours, more commonly 6 or 10 or 12 hours. It is constant, starts as ill-defined, eventually locates to the area where the problem is, and often has typical radiation patterns. There are physical findings of peritoneal irritation in the affected area, and except for pancreatitis, systemic signs such as fever and leukocytosis. Ischemic processes affecting the bowel are the only ones that combine severe abdominal pain with blood in the lumen of the gut. Primary peritonitis should be suspected in the child with nephrosis and ascites, or the adult with ascites who has a mild generalized acute abdomen with equivocal physical findings, and perhaps some fever and leukocytosis. Cultures of the acidic fluid will yield a single organism in garden variety acute abdomens. A multiplicity of organisms grow. Treat with antibiotics, not with surgery. The treatment for a generalized acute abdomen is exploratory laparotomy, with no need to have a specific diagnosis as to the exact nature of the process. If it does not look like primary peritonitis, one of the exceptions, we only need to rule out things that may mimic an acute abdomen like myocardial ischemia ECG, troponins, lower lobe pneumonia chest X-ray, PE immobilized patient, or things that specifically do not require surgery like pancreatitis, amylase or lipase and urinary stones. CT scan of abdomen. Acute pancreatitis should be suspected in the alcoholic who develops an upper acute abdomen. The classic picture has rapid onset for an inflammatory process a couple of hours, and the pain is constant, epigastric, radiating straight through to the back, with nausea, vomiting, and retching. Physical findings are relatively modest, found in the upper abdomen. Diagnose with serum or urinary amylase or lipase serum from 12 to 48 hours, urinary from 3rd to 6th day. CT of diagnosis is not clear. Treat with NPO, NG suction, for fluids. Biliary tract disease should be suspected in the fat woman in her 40s who has 55 children, and who develops right upper quadrant abdominal pain. Ureteral stones produce sudden onset of colicky flank pain radiating to inner thigh and scrotum or labia, sometimes with other urinary symptoms like urgency and frequency, and with microhematuria in the urinalysis. CT scan is the best diagnostic test. Acute diverticulitis is one of the very few inflammatory processes giving acute abdominal pain and the left lower quadrant in women. The tube and ovary are other potential sources. Patient is middle-aged or beyond, and there is fever, leukocytosis, physical findings of peritoneal irritation in the left lower quadrant, and sometimes a palpable tender mass. CT is diagnostic. Start treatment with NPO, IV fluids, and antibiotics. Most will cool down. Of those who do not, about 90 have an abscess that can be drained percutaneously by the radiologist. The few that cannot will need emergency surgery. Any patient who has survived 2 episodes of acute diverticulitis should have elective surgical removal of the affected area before they get into trouble again. Volvulus of the sigmoid is seen in old people. There are signs of intestinal obstruction and severe abdominal distension. X-rays are diagnostic, as they show air fluid levels in the small bowel, very distended colon, and a huge air-filled loop in the right upper quadrant that tapers down toward the left lower quadrant with the shape of a parrot's beak. Proctosigmoidoscopic examination with the old rigid instrument resolves the acute problem. Rectal tube is left in. Recurrent cases need elective sigmoid resection. Thanks for watching. With our best wishes. Number 1 Doctor with my best wishes. Dr. Atif Ahmed.